Dear colleagues, we warmly welcome you to the AECP Grand Round Charitable Foundation, Sergei Malayan Eye Care Center, and the Department of Ophthalmology of Yerevan State Medical University discussions. We call this AECP Grand Rounds, and today is another meeting for us, and I'm Nana Yazay, I'm the director of the Armenia Eye Care Project. I'm pleased to note that the scope of our meetings is expanding, and it's including new departments, new areas in ophthalmology. And today, within the framework ICP Grand Rounds, we'll be presenting interesting cases from eye trauma department from Sergei Malayan Eye Care Center. We'll hold our discussion, as always, with our colleagues from Armenia and US, and we will summarize the 2024 ICP Grand Rounds. From Armenia, we'll have the chairs Georgi Grigoryan and Levon Grigoryan, and their colleagues also join us. Let me introduce Georgi Grigoryan, who's ophthalmologist and surgeon, PhD. He's the head of eye injuries department at Sergei Malayan Ophthalmology Center, and Levon Grigoryan, ophthalmologist and surgeon, ophthalmologist of the eye injuries department of Malayan Ophthalmology Center. From the US, our colleagues has joined us, Faraz Rahal and Matthew Wade, and John Havanesian will join us a little later. Let me introduce our friends, our guests from the US. Faraz Rahal from California, US, ophthalmologist and surgeon, the co-owner of the Retina Vitreous Associates Medical Group, co-director of the Retina Vitreous Associates Medical Group, and University. Also, he's co-director of the program at the University of California and the clinical associate professor of Jules Stein Eye University at the University of California, Irvine. Matthew White, California, U.S., ophthalmologist and surgeon, clinical associate professor at the Department of Ophthalmology, Gavin Herbert Eye Institute, University of California, chief of Corneal Service and ophthalmologist of Veterans Affairs Hospital at Long Beach in California, U.S. Also, let me introduce John Havanesian, who's ophthalmologist and surgeon, member of American College of Surgeons, member of Harvard Ophthalmological Association, professor of Jules Stein Eye Institute, University of California, vice president and board member of the Armenian Eye Care Project. I'm sure that the presented material will be very educational and it will supplement the knowledge in this field. Let me remind you that your questions can be directed to the speakers in the Q&A section in the Zoom platform. And the ophthalmologists that will participate in the event completely, they will receive the CME events. And now I'd like to kindly pass the floor to Dr. Georgi Grigoryan. Hello, hi, dear colleagues. Today, we're really pleased to talk to you again. We are very familiar with each other. We know your knowledge, we know that you're with us today, and I want to greet this project, the Ground Round. This is a great, this follows a great educational aim, and I would like to thank you for joining us today. I would like to ask Dr. Levon Grigoryan to present the topics of our discussion today, and we can start our scientific part. Hello, dear colleagues. Hello, dear guests. I hope that you're all doing great. We have two topics, two presentations, and the first one will be presented by Dr. Susanna Yepremian. She will be presenting the work in the eye trauma department. We'll talk about intraocular and extraocular foreign bodies, cases, the management, and the removal techniques, and we will talk about several cases. And the second talk will be presented by Diana Dumanyan, and she will talk about retinal peripheral degeneration and in which cases we should do laser interventions, in which cases we shouldn't do that at all. And she will present a clinical case that we worked on in the trauma department. Thank you. Hello, everyone. First, I would like to thank Armenian Eye Care Project, also Sergey Malayan Eye Center, the traumatology department. Thank you for this opportunity. And today we're going to talk about intraocular and extraocular foreign bodies, the types, organization, diagnostic methods, and also the removal techniques. And this topic is especially important because people that are working with metals, they don't follow the safety measures, and we will talk about several clinical cases as well. Ocular foreign bodies are classified into extra and intraocular. Extraocular foreign bodies are conjunctival, corneal, inlet and orbital, and intraocular ones, they're subclassified into anterior and posterior segment. The anterior segment foreign bodies may be placed in the anterior chamber, iris, posterior chamber, lens, and in terms of the posterior segment, they may be located in vitreous cavity, retina, choroid, and sclera. A few demographic features. Foreign bodies are the 20 to 40% of the open globe injuries. Two-thirds of the patients are usually young people, occupying the age range from 21 to 40 years. 95% are males, and the most common trauma is due to chisel and hammer injury, also in industrial work, roadside accidents, and maybe due to blast or weapon-related injuries. Most common bodies are iron and steel, and the less frequent are glass, stone, plastic, wood, and aluminum. In terms of extraocular ones, the conjunctival foreign bodies are usually forming local inflammation and the feeling of a foreign body, but in other cases, in organic cases, then also this may develop conjunctivitis. The corneal ones are the most frequently observed. These foreign bodies are usually they may be very dangerous because this may complicate with fungal and bacterial corneal inflammation. We need to evaluate this properly, how deeply it's located in order to, in terms of the future management. When the foreign body is placed within the eye, it may have different effects. The most frequent one is the mechanical effect. It may cause infections, and there may be specific reactions, and also this may lead to sympathetic ophthalmia. The mechanical effect depends on the size of the body, the type, the speed, and also the fissure that it creates, the area where it penetrates the eye, and the place where it's located in the end. The mechanical effects are corneal perforation, hyphema, iris perforation, retinal rupture, cataracts, choroidal ruptures, hemorrhages. And also you can see it here, but also retinal tears and detachments. The reactions that may be caused by foreign bodies. There may be different reactions based on different types of materials. For example, if they're neutral, there will be no reactions at all. But other kinds of foreign bodies, they may lead to local inflammation, necrosis. Also, specific reactions may be caused by iron and copper, specifically in terms of iron siderosis and calcosis due to copper. Intraocular infection is a very important risk for eye, and unfortunately, the intraocular infection, when it's confirmed, it may lead to eventually to panophthalmitis. Sympathetic ophthalmia is a panuveitis that's developing in one eye, and due to the trauma in other eye following like surgery or the trauma, we don't really know the real cause for this, but probably there's probably a late autoimmune reaction to specific antibodies. Diagnosis and localization are important for the future management, and we will need to um, do this in stages. So firstly, we need to evaluate the patient history, very detailed one, especially in the moment when the foreign body entered the eye, what happened at that point. We need to check visual acuity, a papillary examination, and then perform ocular examination with a slit lamp, fundoscopy, gonioscopy. Also, if there is a foreign body in the anterior chamber, it's very important to localize it properly. And in this case, we'll have radiography helping us. The, the most frequently used one is the X-ray, ultrasound, B-scan, UBM, CT is the best option to evaluate the localization of foreign body, and for MRI, you shouldn't perform that if there's a magnetic foreign eye. The removal of foreign bodies from anterior segment. Firstly, in conjunctiva, they may live on their own, but if they're corneal or if they're superficial, you may use 26 gauge needle or the tweezer. If there is a risk of perforation, you should remove intraoperatively in order to avoid complications. If the bodies are magnetic in the anterior chamber, in that case, you can remove that with a magnet. If not, you can use tweezers. And removal of foreign bodies from posterior segments. So firstly, it's the first method is parsplana vitrectomy, and we need to understand if we should do that with one stage. Should we just close the eye, close the wound, and perform the vitrectomy, or we need to do it in two stages? Do the first sanitation, and then after some time we can do the PPV. In this case, we need to consider the state of the patient, whether the patient is ready for a long one-stage surgery. Also, we need to consider the availability of surgical team. Before surgery, we need to provide wide spectrum antibiotics for our patient. And in the end, if we have a retinal tear, we need to perform prophylactic retinopexy. Here you can see intraocular foreign body in the stroma. This is in cornea, in the depth of cornea. We remove using tweezers under a focal lamp. We do that in trauma department. In the limbal area, we're performing paracentesis. And then we remove the foreign body from that area. We just we use the forceps to remove that from the opening area, and we use the magnet to extract the body. We check with the magnet around the wound whether there are any remaining parts for this body. It's in the anterior chamber. We're using the magnet to extract some part of the foreign body, and then we are extracting it and sewing the wound. And in the end, we can see
Otel mining shaping
the foreign body in the posterior segment. It's in retina.
otel mining mușchi pe
We're seeing the cornea, the fissure due to entrance. There's a traumatic cataract going on here. We perform vitrectomy. Identify the foreign body. It's in the macular area. We're using forceps to extract the foreign body. Here we also perform a papillary retinopexia and implantation of the pupil. This will be all. Thank you very much. Would you like to leave the commentary or you want to continue? I would like to add some stuff. Firstly, I would like to mention stress to everyone that the job that was performed, we performed it in trauma department in Malayan Ophthalmology Center, and we didn't use any images and videos from internet. Dr. Georgi Grigoryan performed this, so this is one of the achievements of the trauma department of Malayan Center. Just one thing in terms of intraocular foreign bodies, and the presenter didn't mention that retinopexy was performed using laser after the removal of the foreign body around macula, and we used silicone intervention in this case. Thank you very much. This was a great presentation. I'm sure there'll be questions, and we will definitely have questions to our colleagues from the US, and I think we should proceed with the second talk. I wanted to say something as well. Susanna said a very important thing in the beginning, and this is very specific to Armenians. We don't like to protect ourselves, and 90% of these cases wouldn't have happened if we could have protected ourselves, like used personal protective equipment, if we were something that would have prevented that trauma. So basic carefulness that not handling it properly leads to very severe trauma, and after trauma the result is you can't give a proper prognosis. It's very difficult to provide a prognosis because in the center of the center of the eye was damaged in one of the cases, and it will be it's responsible for the main vision. So the second presentation, Diana Dumanyan will talk about peripheral retinal degenerations. She'll present the talk. Why did we decide to handle this case in trauma department? This is a very important issue here, the short-sightedness, and it will be important to present the cases that have to be intervened. There are cases that you should intervene and you shouldn't intervene. Hello, everyone. Today I will present pathology, which is one of the leading causes for retinal degeneration and detachment. This is a pathological case that's involving not only the retina, but also the vitreous body and choroidea. The pathological pathway is not completely understood. It can happen in one eye, in both eyes. It doesn't depend on gender. Risk factors are age, myopia, astigmatism, hypermetropia, the degenerative processes. Usually the degeneration is mostly observed in people with myopia, but there is no direct connection between myopia level and retinal degeneration. atherosclerosis, diabetes, hypertension. This also have a role, also genetic factors, also other trophic factors, uh, vitreous body diseases, uh, vitreoretinal traction causing conditions, also conditions that lead to the classification is equatorial, peripheral, and mixed. Equatorial degenerations are divided into lattice degeneration, isolated retinal tears, and pathological pigmentation. The latest one is a non-progressive pathology. It's not an indication for peripheral photolaser coagulation, but we'll talk about the first two. Peripheral degenerations are usually the cystoid degeneration, retinoschisis, and chororetinal atrophy. In terms of symptoms, we have cases with symptoms and without. Usually, the ones that have symptoms, these are at higher risk for retinal tears and detachment. The most frequently observed symptoms are the peripheral vision loss, photopsia, which are due to retinal irritation and traction, and also floaters that are usually caused by tears. In terms of the risk, the degenerations are divided into three groups. The first one is the high risk group with flap tears, penetrating tears, and non penetrating tears that are combined with vitreoretinal tractions. These have absolute indications for photolaser coagulation. In the moderate risk, we have penetrating and non penetrating tears that are not combined with vitreoretinal traction, and there is subretinal fluid accumulation. And if we do a proper follow-up, this may be a relative indication for photolaser coagulation. In the lower risk, we have isolated tears that don't have vitreoretinal traction and they're not combined with subretinal fluid. Lattice degeneration. It's subdivided into the classical typical lattice degeneration and the Snell-Track degeneration. In this case, you would prefer the photolaser coagulation, retinal erosion, and then postequatorial lattice degeneration and snowflake-like retinal changes. In the last two cases, the risk for tears and detachment is the lowest. Progressive thinning of the retina, vitreous body changes. In this case, we'll have an indication for photolaser coagulation. And this is leading to traction, vitreoretinal traction. In case of retinal degeneration, the peripheral photolaser coagulation is performed in the surrounding area, and this is leading to aseptic inflammation. Isolated retinal tears. According to etiology, this may be the symptomatic cases are leading to isolated tears up to 90%, and in asymptomatic tears, these are only 1 to 1.5%. The photolaser coagulation is performed around the tear up to 2 flap sizes. In terms of the flap tears, the peripheral photolaser coagulation is an absolute indication because we have the accumulation of the fluid and vitreoretinal traction. So we'll have two approaches for the management. If the patient was referred early and we have fresh enough time, and we don't see retinal detachment on ultrasound, then we can do a follow-up and continue with conservative treatment. We'll try to see whether it's absorbing. And in the flap tears, we're doing not just in the area of the flap, but also in the fundal area. And the other type, when we have the hemophthalmos Also, in the flap tears, in the giant flap tear cases, so they're called giant when the size is uh, more than 1/4 of the quadrant. This is a very high risk. There's a very high risk for retinal detachment, and these are usually combined with hemophthalmosis. Retinoschisis. We have acquired retinal degeneration, presenile, senile, and myopic. Secondary retinal degeneration that's caused in response to a chronic ocular issue, and in both cases we don't have the indication for peripheral photocoagulation, and congenital ones is juvenile isolating retinoschisis. It's mostly observed in men, and it's unusual since there's also retinal schisis in addition to the peripheral retinal tears. Wagner's disease, which is observed in both boys and girls. We see myopic retraction, and the feature is that we also have destruction of the vitreous body. We also have indication for peripheral photo laser coagulation and Fabry-Goldman disease, in which case the peripheral retinoschisis of the retina. We also have the abiotrophy, and we don't perform the peripheral photolaser coagulation. And as a conclusion, the optimal indications when we have retinal detachment in the other eye, aphakia or artifackia, all symptomatic cases, progression of the disease, they unblock retinal tears, and retinal cysts. Also, the contraindications, which are general and local, or general ones, we have severe somatic condition, high hypertension, which is uncompensated, decompensated, diabetes mellitus, and acute infectious diseases. In terms of ocular ones, acute ocular infectious processes, decompensate glaucoma or ocular hypertension, insufficient transparency of the eye's optical media, which will prevent laser coagulation. Now let's talk about a clinical case. 61-year-old male was referred to the Malayan Ophthalmology Center, had floaters in his right eye, didn't mention photopsia, had glasses for farsightedness. During the examination, we see the visual acuity in both eyes. It's 1.25 and overall is 1.5. After refractometry in right eye 1.25, in left one 1.5, keratometry 39.85, in the left one 40.47. Intraocular pressure was within the normal range, and the axial eye length, which was kind of important for us, in the right eye is 24.86, and in the other eye it was different, and we have a giant retinal tear without detachment, time from 4 to 8 o'clock. So the whole lower quadrant, and in the left eye we have lattice degenerations in the both superior and inferior peripheral areas of retina, and the images are following the photolaser coagulation. In the right eye, with a B scan, we can see the tear diagnosis in both eyes. Hyperopia low level, giant retinal tear in the right eye and in left eye, lattice degenerations. We decided to perform in the right eye photolaser coagulation around, forming a demarcation around the giant tear. And in the other one, we decided to perform the prophylaxis, photolaser coagulation. So giant retinal tears are connected to a higher risk of detachment, but early identification can help to prevent further complications. We can perform the photocoagulation in one eye, but the other eye that's normal should always stay under follow-up. So, shall we start our discussion? Let's interpret firstly, and then we'll refer to our colleagues. In terms of in similar cases when we have hemophthalmia and when we're talking about vitrectomy, yes, when if if you can manage um, without retinal detachment, uh, when you have the blood retraction, of course, this will be the perfect case scenario. But there are cases when we need to intervene very fast. I'm just asking everyone that's looking at us, and maybe if they're from the primary care, from the outpatient primary care centers. In such cases, we have cases, many cases, when people are undiagnosed and they have detachments, and when the detachments are old, and it's very hard to do the surgery. It's very you shouldn't just follow the hemorrhage and miss the tear, because in many cases when the patients are referred to us and the cases are missed, you ask them, you collect the history, and they're like, yes, we visited our physician. They say there's some blood in your eye and it will just go away and everything will be fine. However, they're using anti-VEGF, which is there is no point in using this because blood and anti-VEGF don't have any. You should normally do this. If you have a case like this and if you don't have the devices to do this, we're asking you to refer to the clinics, to the specialty clinics, because in the end, these patients are visiting us with retinal detachments, and the prognosis isn't that good. And why did we decide to talk about the myopic cases? Because why did we want to talk about the dystrophic cases? We have to be honest. There are cases, and these cases are increasing in their amount, that were also in other countries as well, also in Armenia, in other clinics. We see cases when patients, when you, not that you shouldn't do a laser, but like there was no point in doing any laser intervention. Understand that with the laser, people feel good about laser. Maybe this is a new era, maybe this is a new specialty that everyone wants to follow, but you shouldn't forget that laser intervention has contraindications, and you shouldn't reach to the point, especially in young patients, when we have contraindications, and this leads to a worse case. And Dr. Rahal, what's your opinion? I'm sorry that we're talking in Armenian. It's just the format of our meeting, doctor. But of course, let's talk about both topics. Mostly, I want you to interpret intraocular foreign body management. What are the news in this field? What new surgical methods, maybe new types of forceps or magnets, new types, maybe. And the second very important question, our case represents macular area damage, but in many cases, we have intraocular foreign bodies when the macula should have been protected. We're discussing this very much. What shall we put on macula to so that foreign body wouldn't damage the macular area automatically? There are cases when they're using heavy hyaluron. And also, I wanted to add interpretation. We have some experience with this, and it has some negative sides. Of course, the fluorocarbon, when you insert it, it's very difficult when when it enters the fluorocarbon. It's very hard to remove this. And your opinion in this case, what would be your update on this?
I actually approach most of the foreign body posterior segment cases the way was described here in some of the slides, which is it's based mostly on it's based mostly on the size and location of the foreign body. I don't think there's anything really great that's new compared to what was already discussed. I tend to not use the magnet very much. I don't favor the magnet. I think it's uncontrolled. If it's at all possible for me, I will use a forceps to take it from whatever part of the eye that I find it, even if that's embedded within the retina. I'll try to loosen it and take it off with the forceps. Whether that's a large forceps or a small forceps, of course, depends on the size of the lesion of the material. And then if it's not too large, I just pull it out through the sclerotomy that I've enlarged, as was shown in the video that was presented. That was excellent. If it's extremely large, and I've done some of those that were surprisingly large in the vitreous, I'll uh, I'll take it out through the limbal incision of the anterior chamber, again with the forceps if possible. So rarely do I use the magnet anymore. I do use it once in a while if I can't find the foreign body through massive hemorrhage or clouding. I almost always do a lensectomy in order to visualize the back of the eye. Usually the lens has been perforated anyway. I do not usually place an intraocular lens at the time of this kind of surgery. That usually for me is done in a staged manner. As far as the protection of the macula, I don't think either is really that protective, either the viscoelastic or the perfluoron. But if I use anything, I'll use perfluoron so I can see it a little better to take it out. But your point about it can make it sometimes more difficult to manage the foreign body, uh, to have it sink inside these liquids is true. I think sometimes they can get in the way of removing the foreign body. So I don't usually do anything to protect the macula other than my careful trying to be very careful with the forceps. But if I do any protection of the macula, I'll usually use perfluorocarbon and take it out after I've removed the foreign body.
Anche le veli.
Մենք թարգմանություն ոնց է։
Անգլերեն գնանք էլի ավելի լավ, հա. Thank you for your advices, Dr. Rahal. So in this case, why we sometimes when we are removing, we're trying to do with the forces definitely to remove the intraocular forest bodies. So sometimes why we remove it in this case with the, you see when we start to remove with the forces and after we became to the magnet, because sometimes it's stucking in the wood. It's in the wound stucking, and we're just helping him to come out with the magnetic. Definitely, magnetic is an unmanageable thing, and so if you can, you can do it. You can do it with the forceps. Definitely, you need to do it. And about removing from the entire segment, definitely, it's all right. But if you have a damage of the posterior capsule, if you don't have any damage of the posterior capsule, I'm sorry, I don't think it's necessary to remove it from the anterior chamber.
No, I totally agree. My preference is to take it out through the back if it's possible. The cases that I'm describing from the limbus is that it's such a huge injury in foreign body that the lens is universally damaged in those cases. But indeed, if the lens is intact, the capsule of the lens is intact, there's no reason for lensectomy or any anterior segment incision or work. I would avoid that completely and do as was shown in the video, which is just expand the sclerotomy. I would work usually with the small sclerotomy until I've achieved where the foreign body is, and then I would usually extend the sclerotomy and pull it out. I've actually done this a couple of times in difficult situations with dislocated IOL. In fact, I did one in Armenia as an assistant while I was there because in that case the anterior chamber IOL was in the eye already and the dislocated posterior chamber lens was in the back of the eye. And as opposed to removing the ACIOL and making a large incision, we picked it up and made a incision extending the sclerotomy and pulled the IOL out through the sclerotomy, much like a foreign body. I like that technique a lot, and I agree with you 100%.
I think in time of the surgery, I was there, if I don't mistake. Yes, we were together with Astik was Azarian. So, and about the second topic, About the second topic, in which case to do the laser treatment of the posterior peripheral degenerations. So, as you heard, nowadays we see a lot of patients that there is no need to do the laser, but they already have the laser. That's why we decide to do this kind of lecture today to show the doctors in which case they need to do or not to do. Thank you.
Yeah, that's wonderful. We have a similar situation here in the States where we try to educate the general ophthalmologists and optometrists about which cases really need photocoagulation and which don't. And of course, there's a lot of judgment and some disagreement about how aggressive or not aggressive. I tend to be pretty conservative with the frequency of photocoagulation. I generally treat all the horseshoe tears. In that instance, even if they're asymptomatic, I'll treat a horseshoe tear. But asymptomatic lattice degeneration, even with atrophic, if there's atrophic holes only with but no evidence of a significant vitreoretinal traction at the surface of the hole, I don't treat regular atrophic holes or lattice degeneration almost ever. Except the exception for that, as was shown also nicely in the slide demonstration, is in the second eye of a patient who's already demonstrated a retinal tear or retinal detachment. So if the contralateral eye of a patient who's asymptomatic has lattice or holes, I'll treat them if their contralateral eye had a previous retinal detachment. But in asymptomatic patient with no history of retinal detachment, only the horseshoe tears would I treat with laser. The rest I
Yes.
observe.
Yes, and what about urgent surgeries? So I will share you experience in India. So we are surgeons. What are they doing? If they have a young patient with the no diabetes, no hypertension, they see their blood in the vitreous. Directly, they're going to do vitrectomy and to treat it with the laser. So not to avoid the retinal detachment. So is it right or no?
No, I don't think vitreous hemorrhage alone in proliferative diabetic retinopathy without B-scan evidence of a retinal
No,
detachment
I mean,
doesn't.
I'm sorry to interrupt you. It's a case
Yeah.
of the horseshoe tears.
Oh, horseshoe tear. Yeah, excellent. So also not necessary to do right away vitrectomy. Some doctors prefer it if the patient is really nervous and pushing for it, but most of these cases can be managed with frequent visits and frequent B-scan ultrasound, enough time for the hemorrhage to clear somewhat to apply laser photocoagulation or even cryopexy. These are cases that I'll sometimes use cryopexy. If you look around the perimeter of the hemorrhage, the peripheral retina can sometimes be seen reasonably well with scleral depression, and the tear can be seen even through the hemorrhage. If so, it may be that it's too cloudy for laser photocoagulation, so I will use cryo to treat the tear. I have many cases with cryo alone, and then the hemorrhage clears by itself with excellent results. So I don't think emergent or urgent vitrectomy has to be performed. If there's obviously any retinal detachment on the ultrasound, that's different. But if the ultrasound is negative for retinal detachment, I tend to be conservative and wait to apply retinopexy or immediate retinopexy with cryo if I can see the tear.
Thank you for everything. Yes, the cryo is a very good thing. Yes, if you have a guess. Can we say hello to John? You hear us?
John,
I
hi.
do.
Hi, dear.
Hopefully you can hear me. It's nice to see you all. And Faraz, thank you for doing this. Matt Wade, thank you for doing this. Nuneth and team, thanks for setting this up. I apologize for being late, but this looks like it's a really valuable meeting. I actually have a question for Faraz. So in the decision to clear a non-clearing vitreous hemorrhage, does the B-scan presence of a posterior vitreous detachment prompt you to be a little more ready to do a vitrectomy, or does it not change the decision making?
I think it does change the decision making because the ease of the surgery and the reduction of risk of complications is definitely there if the PVD is there, meaning much reduced risk of creating a retinal tear. If the context is that there's a PVD and the hemorrhage is even a little bit slow to clear and the patient's frustrated, yeah, I'll accommodate and I'll do a vitrectomy in those cases. For sure, and it's sort of patient driven. How some people are risk averse, and if they say, I'm comfortable to stay cloudy for several weeks, if you're comfortable, they don't do the surgery. Others, depending on work requirements and a function, might say, I can't wait 6 weeks for this to clear. I'd rather have vitrectomy. And if the PVD is present, to your point, that makes it
Yeah.
an easier decision for me to do early vitrectomy. It's an easy case generally.
Yeah.
Definitely, you're right, Dr. Rahal. Thank you.
And Georgi and Levon, it's great to see you as well and
Thank
your
you.
department.
Thank you. Thank you. Some kind of any opinion of from you about the myopic cases, which cases you need to do a laser treatment, like peripheral degenerations, and in which cases you doesn't need to do anything there, just watch, follow up.
Most cases for me, if they're asymptomatic, I'm watching for follow-up and not doing photocoagulation. Again, the exception is any horseshoe-shaped break in the periphery, asymptomatic or otherwise, I'll treat because I think, as was shown on the slide, even though it's a small percentage of people that progress to retinal detachment with an asymptomatic horseshoe tear, it is still 1 or 2 or more%, and it's an easy procedure to do the laser in that case. But anything short of a horseshoe tear, asymptomatic, high myope, I just observe, and part of the reason is to treat those people. They have so much peripheral pathology. Often if you don't really have a focused area to treat, like a horseshoe tear, you might end up doing 3 or 4 quadrants of laser, which is a fairly significant amount, might potentially create some epiretinal membrane. So I tend to be conservative if neither eye has ever had a retinal tear or detachment.
Thank you for your advices. I heard the Matt is here too, yeah? We didn't see you there. Matt, you're here? You hear us?
Dr.
He's
Wade,
probably
are you here?
chasing after one of his 4 kids. Early hour in the morning.
Yeah.
We went through the books that you sent to us.
Good. Yeah. Yeah. Thank you. It's good to
And
see
one
you.
question for you, John. What do you think about the prophylactic laser treatments for the myopic eyes? Is there any necessity to do that or no? I think, my opinion, no. If there is no symptoms or there is no some kind of changes, there is no need to harm the retina. I'm sorry.
Yeah, and primarily for us, that question arises in the context of cataract surgery when we're going to be going in and doing it. And so if I have any question, I always get opinions from my retina colleagues. And I'm always, when we see that there is a PVD before cataract surgery, we know even in a highly myopic patient that the risk of retinal detachment is not that great. If the PVD has already happened, as Dr. Rahal was just mentioning, that risk goes down. But we usually defer to our retina colleagues, but rarely do they do laser photocoagulation unless there is evidence of traction or something, an impending detachment, or as Dr. Rahal mentioned, history in the other eye of detachment.
So, Dr. Rahal, I'm sorry, you're here. Yeah, you heard us. So,
Yes.
is you're doing the way that if there is in one eye is retinal detachment, like in myopic eyes, in like in a left eye, there is no changes. So you prefer to do prophylactic laser or no?
Not if there's no physical findings, and this comes up literally every day, several times in my clinic. The detachments I'm fixing are, I'm following them post-op, and all of them ask me about their other eye, what's going to happen now, and I tell them I'm going to look carefully with scleral depression and indirect ophthalmoscopy, and if we see any risk lesion, then we'll treat it. And by risk lesion in that case, my threshold is lower than in the regular patient. This patient, if they have patches of lattice degeneration or atrophic holes, I will treat them with photocoagulation in the second eye in that setting. But again, if I look carefully and have a good view and don't see any of these kinds of pathologies, then no, I don't do prophylactic laser in healthy normal retina. I actually think that could raise the risk of getting an atrophic hole in what is normal retina that you laser. Yeah, the laser itself could, in theory, create some risk of a hole if you're treating in totally perfect normal retina.
So yeah, it's very good advices. Thank you once again.
Thank you very much. We'd like to thank our colleagues, Dr. Rahal, John. John, you're my very good friend. We're very grateful. Thank you so much.
My first trip to Armenia was with you, Georgi, and I remember your kindness and how much I learned from you, and what a good time we had together. So yeah, that's a long friendship, almost 4 years ago now.
Dear friends, thank you for sharing your time with us. Thank you for the good advices. I hope we will see you soon.
I'd like to add that I also had a great experience there, and I want the audience to know how great these doctors are that they're watching on the podium today and others. This is a fabulous department of ophthalmology surgeons. I was very impressed and enjoyed my time together.
Wonderful.
And Frost,
Actually, we
we're
would
going to
like
get you
to
back to
just
Armenia.
thank them.
Yeah,
Yeah, we would like to thank you, John and Dr. Rahal. It's really an honor to have you here.
And let me thank Dr. Levon Grigoryan and our younger colleagues that participated today. And let's conclude the 2024. I think that up to 25, we won't really meet. And I wish all of you all the best in the 2025 year.
So all the best in the coming
Bye-bye.
Merry
Thank you.
Christmas.
Merry Christmas.
Merry Christmas. Thank you very much. Have a nice day.
Bye-bye.
Bye-bye.
Thank you.
Bye bye. Thank you.
Bye bye. Thank you.